So good afternoon, everybody. I'd like to welcome you to this symposium. My name is Hajo Kömer. I'm a pharmacologist by background, and I'm the CEO of Charité here in Berlin. The topic of the next 90 minutes is the digital transformation of prevention. And I would like to convince you that at the end of this 90 minutes, you're so convinced as I am that we should tackle this combination, which is at first sight something which doesn't have something to do with each other, prevention and digitalization. And what's the background of this combination? It's a bit in our country driven by a very strong effect on our society, which is the demographic change in our society. And Germany, Singapore, and Japan are the three countries most affected by that, which will have a major impact for our health system in that we will have a great number of elderly people who will go to the healthcare system, while the younger part of the society in numbers will be much smaller and has to keep the system going. And if you think about ways how to keep this system going in view of demographic changes, there are two major points which are obvious. One is digitalization. Everything in a hospital which needs not to be done from humans by humans can be digitalized. And the other thing, of course, is avoiding, in the widest sense, that people get sick and subsequently to a hospital. And this is what we call prevention. So we would like to work out that prevention is absolutely necessary, and to get into a contemporary stage of development. One of the points which, from my point of view, is essential is the combination of prevention with digitalization. Take the power from both worlds to build a system which, at the end of the day, will help us all to get our systems, our health systems going, and to get our health systems in a really sustainable way. And in order to discuss that with you in the next 90 minutes, we plan to have an extraordinary group of people with us. One of them, Peter Gocke, had to cancel this morning because he's sick. And I would like to introduce the others in an alphabetic order and convince you that the people sitting here are really an extraordinary group. I do that in an alphabetical order, and the first is Ren Balitzer. He's from Clarity Health Service, and they're the Chief Innovation Officer. He's the founding director of the Clarity Research Institute. And as many of you know, Israel has a very distinct system of health insurances. Clalit is the largest of them. They have, from my point of view, a kind of a unique system of long-lasting electronic health records. And those of you who've been fighting with COVID during the last 2.5 years, I guess most of the people in the room have done so, have noticed that every other week there was a paper in the New England Journal of Medicine telling us what to do with COVID. And this came this came often from Clalit, and most of the times Ran was the senior author on this paper. The next in the alphabetical order would be Molly Beaver. She is from a really famous place. Everybody knows the Mayo Clinic, and she's there, the chair of brand strategy. And I guess that's, again, it's another thing than doing direct healthcare to talk about the brand and the consequences for healthcare in the combination we're talking about. If we move one up to a national organization, we have Tim Ferriss with us. He's from the NHS in England, and he's the National Director of Transformation at the NHS in England. And then with us, at least digitally, is Shobana Kamini. She's from the Apollo Hospital Enterprise. She's the executive vice chairperson there, and she has the ability to provide data from really large groups, and she will talk about that. And finally, we have Elizabeth Staudinger with us. She's a member of the managing board at Siemens Healthcare. So I think we have a broad range of expertise at this table, ranging from individual clinical responsibility to a large enterprise like Siemens. So we hope that we can cover all kinds of these aspects. Just to complete this intro, I should say that Ren and Shobana are with us in a digital manner. And the other thing is, I mean, it's a normally sized room. So if anybody of you has questions within, just stand up and ask. I don't think we need to have a fixed time point when questions can start. If something comes up to your mind, just get up and ask it, and we will try to answer it. Would now like to go into a round of introductory remarks. And the question we kind of start with is whether a digital transformation can be a central enabler for prevention, and whether the combination is really a key approach to solving some of the crisis aspects many of our healthcare systems are facing. And we would like to go through that. And maybe we start with Molly Beaver from the Mayo Clinic as we are one person less, you can take your time and carefully explain what you think, and if there are questions, you can answer that. Molly, please.
Thank you so much for for allowing me to be here. So, I want to take you back to when the Mayo brothers founded Mayo Clinic over 100 years ago. They instilled a core value: the needs of the patient always come first, into our institution's culture. And today that remains a guiding principle for us as we continue to create a healthier world where personalized, predictive, and also innovative care is accessible to all. At Mayo Clinic, and of course around the world with these fine medical institutions that surround us, we're focused on solving today's pressing problems in healthcare with a mission to enable new knowledge, new solutions, and new technologies that will improve patients' lives. And so Mayo Clinic has it's called Bold Forward. And the vision really is this: it underscores how we cannot settle for evolutionary change in digital technologies, but to spark revolutionary advances in our ability across the globe to cure, connect, and transform healthcare. We continue to try and work to transform healthcare by leveraging data, technology, and AI innovation expertise to change how care is provided, with the sole purpose of creating a world where the best possible care, which isn't always in the hospital, as we know, and we're going to talk about, but it's available to everyone, everywhere. Thank you.
Well, thank you, Molly. In this, you started with a very fundamental approach at Mayo, and Mayo has been gained worldwide reputation by being a real interventional setup, which I guess nowadays is 95%
Right.
of your activity. Why would you switch such a successful enterprise?
We have it's a new venture. It's called Mayo Clinic Platform, and really what it is as we've been talking about prevention, or what we're hoping to do is gather the medical records, and it's a very lofty goal, but the medical records of everybody in the world, so we can start to predict before diseases and conditions even happen. And we realize that is the future, that hopefully being able to have all of these records, it's really going to be able to help our physicians, our scientists, and our researchers be able to cure diseases and conditions before they even occur.
That's true. That's something we all dream of. Nowadays, reality is that we live on interventions. And the question we might go through within this 90 minutes is what we think about how this type of activity to prevent something is one day somehow reimbursed. I guess that's a key question for everybody who runs a large setup, how you want to really, at the end of the day, earn money with prevention. We all agree that we should avoid things to reduce costs, but how to live on that will be something of major interest, because if you avoid something, it's not 100% that it would have come. if you wouldn't have had the intervention. So it's an interesting change in our entire reimbursement thinking.
You know, one thing I would say about Mayo Clinic is that we are a not-for-profit organization, and therefore, let's say we have a breakthrough of some sort. What we do is we share that with the world, truly, with our medical or with our Mayo Clinic proceedings. And so, what I mean by that is, let's say we have a new intervention of, let's use a hip surgery. We will see patients there, but we want them to be able to get care closer to home so we can, again, focus on the very serious and complex things that we, again, can share our findings and our research and cures to worldwide.
Well, there's a spontaneous intervention from Tim.
Well, you said, you asked the question about a payment system that incents prevention. Well, that's what capitation is.
Yeah, that's true. We can discuss that, the pros and cons of capitation in terms of prevention. That's going to be an interesting afternoon. So I would like now to call Shobhana Kamineni. I told you that she's the executive vice chairperson of the Apollo Hospitals Enterprise, and she runs a setup which, from my point of view, has a unique possibility to go into prevention one day. Shobhana, would you share with us what you do? You should open your mic, please.
Thank you so much. And
How it works.
yeah, good afternoon to everyone. And my apologies for not being there in person. But now, you know, the world has become so accessible, and that's what I want to talk about, the why and the how of digital prevention. So, you know, in many ways, COVID has either accelerated or exacerbated, you know, the way healthcare is looked at nowadays, you know, and it depends on your point of view. For instance, the shortage of healthcare workers. I think that's one of the biggest things that all of us face, whether it's in curative or it's in prevention, because you need a whole bunch of people to be able to even work at preventive centers. And I think that 18 million healthcare worker shortage figure, which they've given, really clearly underscores the ability for digital healthcare to be able to do things differently and to make people more productive. The second use case, or why that I think that digital prevention is definitely a solution, would be the remote access of healthcare that has just made things boundaryless. Just to give you an example, during the lockdown and before, there's a state in India that you know is 14,000 feet above sea level. And there it's very difficult to access, you know, for people to get there, the healthcare workers. We've been handling this remotely, did almost 2,000 emergencies. This is just one use case, but of course we know when geography becomes history, this can go across the world. I mean, we can take medicine, including with 5G, you can do robotic surgery across. So I think that that's a field in prevention and in treatment, which is going to grow very, very rapidly. So, and like Herr Kramer said, that we would probably spend an afternoon just talking about that one subject. So let me move on to a third why and how, which is that, you know, one of the things that has happened over the last few years, while we, you know, very sincerely move towards, you know, the SDG targets, but during the pandemic, these targets have actually gone out of the window. In India, for example, there are 40 million people below the poverty line. And I think across the world, we're seeing this K-shaped recovery of more and more people that can't afford healthcare. And if we don't bring digital in, and if we don't talk about prevention early on, I think that the world is definitely going to face a far greater pandemic than just because of one disease. And that's going to come from NCDs. And what the World Economic Forum predicts is that by you know, in the next 20 years, we'd be spending almost $47 trillion on just prevention activity. So I think that these are very, very advanced examples. But I'd like to close by one particular example, which I think Molly referred to when she spoke about the advanced predictive. And while data will come from all different points of view, and I think all the gentlemen in the room and actually all, excuse me for that, but all the people in the room that represent such huge organizations that you brought together at the table, you know, all of us have this access to large data. For example, our clinical intelligence engine, we worked with Microsoft and we're doing advanced predictive for for Asian cardiovascular prediction. And this is a model that you know we actually put out last year. Is being used in Vietnam, for instance, of course, in India. And I think that this advanced prediction will become more and more intelligent if we can join forces, as Molly spoke about, you know, because the availability of data and how we can put it together very intelligently, I think will be almost the biggest use case for digital prevention for the world. So I'm going to stop there and just say that, you know, these are exciting times, and each day a new use case unfolds. But I think now we've actually come to a point where rubber is hitting the road and we're actually making progress in using this at scale.
Well, thank you, Shabana, for this impressive contribution. Let me say that at least the examples you brought, cooperation with Microsoft and other things, India is much more advanced compared to Germany, for example, right? So there are really things we can learn from each other. And the other thing I really liked was the accessibility story as a new type of build up for prevention, because the conventional way to build up a medical organization system was always to have a hospital, build that up, and afterwards we digitalized it. And this time in prevention, we could just do a reverse build up, starting on a digitalization and then see what kind of hardware we need afterwards. And that is, of course, combined with a high degree of accessibility, and part in remote areas, but also in part maybe in aging populations. So thank you a lot for that. I would like to move on to Tim Ferris. As I told you, he's in the NIH England, the National Director of Transformation. And again, during COVID, all of us, we always have looked at the NHS and to England, because what you certainly had was an excellent survey system. And in times when in Germany we were in deep COVID fog in terms of information, England already could provide, by the systems you have, information which helped us all to come to the crisis. So we are interested on your views on prevention and digitalization.
Well, it's a real honor to be here. Thank you. And I'll have a few remarks on that topic and slightly broader, but let me start with COVID. So the you might even say that we surprised ourselves because actually the infrastructure was in place but had not been connected to the level that it was required. But it didn't take a Herculean effort to connect those systems. And so the fact that we had the ability to connect them was a and is a lasting benefit from COVID, because in fact the data flows in the NHS are dramatically better than they were pre-COVID, and that will persist. I've heard during this conference several people talk about some of the silver linings of COVID. Let me talk about a couple others. COVID taught us that prevention is best delivered both through the medical system and the community, and I'll come back to that point in a second. COVID also taught us that when we deploy digital solutions to providers, we can deploy them at pace. That the opportunity to use adaptive design techniques. You put it in place, it does something, but it's not quite right. You fix it and you do adaptive approaches. Adaptive approaches are not the native approaches in most medical systems. Most medical systems work through a process of large-scale randomized trials, evidence development, rather than an adaptive approach. And I want to connect those two comments to the last comment about COVID, which is COVID taught us that that digital delivery solutions can both speed dissemination, as I just said, but also have the potential, oops, have the potential to, I've lost my train of thought. I was doing something wrong. Have the potential to actually increase health inequalities, because as you, through an adaptive design approach, roll out digital interventions, that has the unintended consequence of having disparate uptake in whatever populations for whatever reasons. But interestingly enough, it also taught us that digital is also the solution to that very problem, because when you roll out digital solutions, you are in the process of doing that, collecting information, and that information allows you to build more targeted, more specific solutions to populations that are not getting the benefit of whatever it is that you're rolling out, like, for example, vaccines. So it both creates the problem and provides the means for a solution to the problem all at the same time. That was a very important learning for the NHS, as it constantly moved to hyper segment different populations that were not getting adequate vaccination coverage, for example. But it was because we had data flows in real time, we were able to pivot very quickly and go after those populations with personalized approaches. Let me switch to prevention priorities. So you mentioned the frail elderly, that demographic challenge. I hadn't previously realized that you were ahead of England but let me reassure you, it's in England as well. And that is a really big prevention priority. Cardiovascular disease, the number one cause preventable death in England. It is also the number one cause of preventable health inequalities in England. Okay. Mental health, highest burden of illness and a really big opportunity for the delivery of preventive services. And of course, cancer and cancer screening, for which we have just finished enrollment on using some of the assets developed during COVID of the Grail Gallieri trial to see if we can't use circulating tumor DNA to completely change the paradigm for how we do cancer screening, a critical building block of prevention. Then let me just say three things. Then I'm finished.
You take your time.
Okay, all right, thank you. On digital, so the NHS is very fortunate to have national data services that provide the definitive site of record for key information about vaccine status and screening results, and the, if you'll pardon the term, interdigitation or interoperability of those national services with vendor services and interoperability services is what I will call the infrastructure architecture of digital health. Remains a really big challenge for us, as I know it is in the rest of the world. But we have recently published some strategy documents that we're chipping away at our ability to understand what a healthy, vibrant ecosystem of the data architecture will look like. We are constantly and I'll just say one more thing, which is it is really important in that data architecture to build toward what we all know and what my colleagues have referenced is that personalized prediction and the personalization of efforts to both nudge behavior change on primary prevention, as well as encourage secondary prevention, even as you mentioned with the frail elderly tertiary prevention. All of those things will be better if we structure our data in a way that allows us to learn, the computer to learn rapidly from that information. My colleague here talked about the platform approach. So I don't know about all records in the world. That's an interesting,
Very lofty goal.
very lofty goal. But certainly we have the ability to do it with the records in the millions of people in England. Pretty big data set for learning and providing opportunities for providing services in a much better, more personalized, more customized, predictive way to get in front of illness, which was your signal to us at the outset of this discussion.
Well, yeah, thank you for that. And I would have two short questions to that. You mentioned that the health system, at least not ours in Germany, would be completely open to adaptive approaches, and that would be kind of the a nice saying of the century to file it like that. Would you have an idea why prevention would be a better goal for adaptive approaches than the conventional healthcare?
I do. Yeah.
Can you share that with us?
Well, because prevention is once a randomized trial has shown that a vaccine works, then the adaptive part is the mechanism by which you deliver those services to the population. And so the risk is fairly low. It's not like you are doing an intervention that has inherent risk. It's really operations in the better delivery to populations, particularly at risk and vulnerable populations, where special or additional measures are very frequently required in order to make sure that you get the coverage that we all aim for. So I think adaptive design is much more suitable in an operational context than it is, for example, for a new therapy.
Well, yeah, it's an interesting point, and I guess in vaccination it's well taken, because the parameters in vaccination are, compared to other prevention types, something either you get the disease or not at the end of the day. And so I'd be really interested in how adaptive designs are. If you go to cancer prevention, or if you go to cardiovascular prevention, where you have multiple factors influencing the final target, where they can hold that. Maybe we can talk about that. And the other thing I really liked was the idea combined with the health inequalities. You said that prevention is a goal to tackle health inequalities. Why would you do that? Why do you think that?
That's the reason why I'm pausing is because it seems so obvious that I'm not sure I know the answer to that question. So I guess because I mean, isn't just well, I'll go to some of the speeches last night, which talked about health as a human right. I guess that's where I would have to go with that question, which is justice and health as a human right. I will just say at the NHS, it is one of the strongest motivating forces that I find when I visit everyone who works in the NHS is overcoming health inequalities. It's a very deep conviction that is big part of the intrinsic motivation of why you go to work in the NHS. And so
well, I'm completely with you. May I go briefly in that direction? The prevention goes in part to directions which are completely self-inflicted, so have been individual decisions of individual people, at the end of the day, leading to a health inequality. I think it depends a bit on how you define the inequality and where it starts and where it stops.
Yes. Yeah.
Okay? If it's a total social determinant, I'm completely with you.
Yeah.
But otherwise, I think in prevention, there's an additional thing, because you prevent parts which are completely self-inflicted by individual behavior.
Yeah. And it's that's a great point. Can I add to that?
Of course.
And just say, what's interesting about that statement to me is that actually inherited characteristics are more and more becoming modifiable,
Yeah.
which makes them more like a socially determined characteristic. Isn't that interesting?
Yeah. Good point. Yeah, really good point. Okay, thank you, Tim. We'll go on with this discussion. The next I would like to ask is Ran Balitzer. As I said, in particular during COVID, for many of us, the system in Israel has been really a central system to be guided through the entire thing. And what fascinates me with Israel is the long-term planning. Now I don't see anybody anymore on the screen. Maybe they are gone.
Oh, we're here.
You're there, Ram? Ah,
Yeah,
nice.
absolutely.
And the thing I wanted to say is that very early on in your entire system, prevention was integrated in a structural way. And it's not only the digitalization, but it's also the going to non-clinical medicine and going to non-clinical preventive medicine very, very early. And I'd like you to tell us what you did.
Sure. So first, it is a pleasure to be speaking here today in such a distinguished group. So thank you again. It is indeed the case in Israel that years of investment in digital health infrastructure in harnessing digital innovation for proactive population health are more and more visibly paying off. And I think most evidently paid off during the pandemic, and I guess we'll talk about it a little more later. And the pandemic was truly a stress test, not just for the health system, but for society in general. And it brought out the strengths and weaknesses in the health system as well. Now, in Israel, we have the benefit of a system made out of 4 large integrated payer providers that usually take lifelong responsibility over the patients and rely on national capitation-based budget. Now, as you said, we will not go into the advantages and disadvantages, but this type of universal healthcare system does make long-term prevention a priority, not only clinically on the individual level, but also financially for the big players. And I think this is one of the key thrusts for why the system is so involved vigorously in preventive health and in using the digital transformation in order to drive preventive medicine. So this is on the incentive side. Now, on the practice side, we have in the last over the last decade been cultivating innovative approaches of population health, and I think most notably and worthwhile discussing is proactive prevention. As you've mentioned, we have over 20 years of individual level integrated health data in our repositories. Using this huge data trove, we've been for the last decade using predictive modeling to assess individual risk scores for health events throughout the entire population, targeting and proactively approaching the highest risk individuals and offering them preventive care for chronic diseases, for diabetes, for coronary heart disease, for renal disease, for cancer, for others. And we try to do this before the deterioration and even the symptoms occur. So this is really moving from the old reactive approach to predictive, proactive approach on massive scale. And we try to do so equitably across the entire system because it's a universal healthcare system. Everybody's covered and we're trying to get to every last patient. Now, maybe an example could help. Let's take, for instance, chronic kidney disease. Many of you have friends or family that are inflicted by this condition. And you know that at the end stage, when you need dialysis or a transplantation, how debilitating and how much burdening this is for the patient, for the family, for the entire healthcare system. Now, when the patient is symptomatic with chronic kidney disease, it's usually too late to make a huge difference on the final outcome. What we try to do is to identify the patients that will have end-stage renal disease 5 years from now and try to intervene today with simple, very low-cost interventions that could completely avert the potential impact. And we've been doing so since 2010 in large-scale predictive preventive approach with an ongoing reduction in the incidence of new end-stage renal disease, thanks to these interventions. If we'll take another example, you talked before, some of the speakers talked about frail elderly and the challenge that they pose to every healthcare system. That is absolutely true. So what we've been trying to do is to identify multimorbid patients at the highest risk of deteriorating to hospitalization. Then we identify these specific patients and we have an intervention that is nurse-led. Nurses lead an intervention that try to create a individualized life plan to live with the multiple chronic diseases and to balance those that are most important. And the outcome of this targeting and individual approach has been shown to be not just cost effective, but actually cost saving. The prevention of hospitalization in the next year after this intervention to the right patients reduces 43% of admission days. And therefore, in the overall costs, is over the amount that is paid for the additional nurses and for the total intervention. So this is not only effective means of providing care and preventing deterioration, this is also, from the cost approach, a sustainable approach to a population that's becoming older, more and more multimorbid. And this, I guess, puts a spiral of death to many of the healthcare systems around the world. And I do think this approach is the right one. One more comment, and then I'll stop and see where we'd like to drive this forward, is that we've been trying to make this predictive, proactive approach something that is embedded in the system, for which we create electronic platforms that put it in the day flow of the general practitioner. We actually pay our GPs at Clalit for allotted time to do preventive approaches through the preventive platforms of the predictive medicine that we've created. And so when they come to the first day of work in the morning, they get paid hours with no patients in place in order to go through the predictive modeling that arrives through their EMR systems, identify the patients with the highest risk and the highest gain of potential intervention, and do a proactive approach to them, bring them in if needed, change their medication, send different types of tests that they would require. And in that way, we put the predictive proactive medicine into the daily practice in a level of millions. And I think this is something that really helps us take it from theory to actual practice and to mass implementation. I'll stop there.
Thank you. Thank you, Ran. I'm always fascinated by this Israeli system. And since you do that such a long time, the integration of prevention and do always the further development, is there a kind of a nationwide ranking of prevention efforts? Because at the end of the day, also in prevention, you will run into a resource question. A GP has X amount of time to spend in prevention. Are there primary targets in Israel for prevention? I mean, you mentioned the kidney thing.
There aren't any national targets on that matter, and I think they are counting on the different, the four big payer provider system to move out of their internal motivation that is driven by their, as I said before, because we are capitation funded and because we take long-term responsibility on the patients, it does make financial sense for us to be preventing illness on the longer term rather than to provide services. We are not getting paid for providing services. We get paid overall on maintaining patients healthy. And so this is a very strong internal motivation that allows us to do this. Within the HMO, what we are trying to do is to say, we know that there is a limited allocation of time and people and provider time that we can allocate to this purpose. And for that, what we try to do is to make the preventive proactive care as easy as possible for the GP, as integrated into their workflows as possible. And the last thing is to make sure that when they receive a recommendation, it has been vetted as the most important recommendation for that day, for something practical that you can do with that patient and you can see the impact in your own eyes. So we are selecting for the very busy GP, we select for him his highest risk patients to deal with in the allotted time that he has. And this is how we try to tackle this.
Okay. Maybe in the near future, you don't need the GPs anymore then, right? We'll see to that. And there are a couple of questions now. Why don't we start with that? Or maybe we finish the round with Elizabeth Staudinger, and then we get into a discussion. I'd be happy if we get a lively discussion with the audience. So the final contribution will be from Elizabeth Staudinger. She's, as I said, member of the managing board of Siemens Healthcare. So get from there a completely different view than from other people who are involved in direct healthcare. So please.
Thank you for giving me the opportunity to speak in a group of very distinguished people working in the clinical field. We in Siemens Healthineers, we're one of the companies working on enabling care that you provide and deliver to patients. And for us, the starting point for us when we look at what do we want to work on or what do we want to do is actually very similar to some of the statements we heard before, for Mayo mentioning this topic of wanting to reach patients regardless of where they are. We had similar ambitions from Apollo, also leveraging the possibilities to really pioneer breakthroughs in healthcare. And all of this is very much in sync with what is driving us. And as a company in Siemens Healthineers, we have a very strong focus on diagnostics, be it in imaging or be it in the lab. And when you think of prevention, of course, the ideal point would be that a person never, ever gets sick and that you can be so effective in managing the health of a population that you never have to treat anything. The closest next best thing you can get to is to pick up things as early as possible. Yeah, and this is where different ways of providing diagnostics come into play. And we heard a few examples already today, how much has moved over the past years, also accelerated by COVID, with remote consultations becoming something which people just do, or enabling a connectivity, for instance, putting ACT into a truck, send it to Tibet, connected via 5G to someone in a different province. And by doing this, enable early screening and early diagnostics to populations in very, very remote areas. So when you think about bringing together prevention and digitalization, I mean, you somehow need a connectivity, yeah, you need data, and you need AI or some intelligence to work with that data. And the basic technological foundations for all of this are there. Right. I mean, there can be new breakthroughs in maybe adding sensors or picking up certain things with easier technologies, but essentially all the ingredients are there. And the vision we are pursuing is really this idea of creating a digital twin, yeah, of a patient, right? Of also centering the information around the individual, yeah, because that's, as a patient, you don't want to be bothered by managing your health. You just want to be healthy and you want to stay healthy, and you probably want to be prompted the moment when something may be on the horizon, which you should take care of. So it's this idea from the individual and this idea of building something which you can envision as a digital twin. And then if you want to reach that benefit for the individual and scale it, yeah, to a society, you have to start connecting the data on the individuals. And I believe the example we heard from Israel is a very impressive example of what already is being done, yeah, and where you can observe also the power of doing these types of looking for these approaches. At the same time, if we get closer here to Europe, where we are today, we probably all know there is a lot of barriers, right? There is a lot of hesitation to really leverage the data available, to connect it, to open it up to research, to really use the power and potential that's inside that data. And if we really want to unleash the possibilities of bringing together digitalization and prevention, I think we have to find ways of moving beyond that.
I think it's again an interesting issue with the digital twin, because if you move to prevention and go away from intervention, you will have multiple factors which are kind of non-medical factors, like social factors, like inheritance and all these other things. So the twin, at the end of the day, if you want to be successful with a preventive twin, needs to integrate something like the biosphere of the entire person, which is an interesting challenge then to you and your company, I guess.
Right, and we're probably not the one company kind of that can make all of this a reality. I think it's also the power of connecting different bits and pieces of the ecosystem. And of course, in an ideal or in a perfect vision of such a concept, all these elements would have to be included. I totally agree.
Okay, and apparently this discussion stirs a lot of questions. So I've at the same time questions from the net, from the chat here, and I would just like take one to Shabana because it's a rather specific question. Somebody would like to know more about your cooperation with Microsoft and whether you were also dealing with Google in preventive data.
So actually, the answer to the last part of the question is yes. We have a large platform that we've created, a digital health platform. And with our clinical intelligence engine, actually Google is working with us a lot in being able to take it to physicians and for us to be able to do the early predictive diagnosis, and is quite successful. But the Microsoft project, I think, is very interesting because like this now we have several projects in play, one for diabetes, one for NASH, liver disease. And what happens is that we use the data of all the patients that had come into us for master health checkups and for any cardiac interventions. And when we connected this along with Microsoft, we would actually be able to get certain parameters that would lead to a predictive score. And I think that has been actually really successful in identifying really early stages of cardiovascular disease. And I think that's something that will go quite far. But we went one step further, and I think this is the exciting, when people talk about the metaverse as a use case. So they actually gave us their HoloLens, and they said, can you use this to be able to create patient education? And with that, when they enter all the parameters, they can actually see the progression of disease. And I think that's where it becomes more and more interesting and really the larger point is that no longer are there boundaries of who is a healthcare provider. I think just about everybody becomes a healthcare provider, and it's a good thing. So we as conventional healthcare providers have to be able to understand and be a lot more agile and open to be able to get these partnerships and actually take it to a larger population and really make it very ubiquitous.
Mm-hmm.
I think it's quite interesting that lots of arguments go a bit away from specific medical into society questions, and maybe we spend some time on that. But now there were several questions here. We start here going to the front. Maybe you coin a short question and ask specifically one of us.
Yeah. Okay. So first, I'm honored to be part of this discussion, and thank you all.
There's a mic. Wow, I didn't see that. Sorry.
First of all, thank you for this very interesting discussion, and I'm really honored to be here. My question, I have many questions actually, but let me start with the first one for Mr. Ruan. I'm intrigued, how can you engage individuals to be part of the program? That's really interesting. I really am fascinated with the program that you described, and also how do you do the predictions on individuals that you don't have data from, right? So that's one question. The second thing is a general question, which is Do you distinguish between individualized programs for prevention and holistic? So we've seen some holistic approaches on preventing things like I can state the collaboration between InstaDeep and BioNTech to detect variants of COVID-19 before they come. That's one thing. And that's holistic. That's to tackle one issue before it happens, right? And to take the right measures. But there is also the individualized, like Mr. Rand specified. So do you distinguish both these kind of strategy, and are there strategies to do that? And one question that is for me is how do you integrate the private sector to help on this, like startups and so on?
Okay.
Thank you very much.
Maybe Ran, you can give an answer on that.
Sure. So let's start with the question on how do we deal with patients we don't have data on. So to explain the way the system works, when you're a member in Israel, you are a member of one of the 4 organizations, and every bit of data of any healthcare utilization that you go through is actually recorded in the data platforms. So it is the case that except for those of people who only joined us yesterday, in which case we have very little data on them, but vast majority of our population, over 90%, usually are born at Clalit and would 82 years later die a Clalit member. And throughout this time, we have their full record, their inpatient data, their outpatient data, fully integrated, including additional social data and additional information that flows in. And nowadays we're putting in more and more genomics data, data from sensors and continuous data, and of course imaging and all of that. So data paucity is not a great problem in the vast majority of population, and it's actually the data deluge, the overflow of data, that is our biggest challenge, and also deciding what do we focus on with all of the different opportunities that we have. So this is regarding when you don't have data. I would mention one example, though, from COVID. At the very early time of COVID-19, as early as March 2020, we wanted to introduce a predictive, proactive approach to approach our highest risk patients for severe COVID-19. But at that time, we did not have cases in Israel yet. So how do you create a predictive model when you do not have actual patient data with COVID? So what we did at that time was to take our, our old model for predicting flu complications, influenza complications. We have an ongoing model that works on it on a yearly basis on predicting which of our patients will have severe influenza during the coming winter. So we took that model and we took the data that came in from China and Italy on the relative mortality between different age groups that was available at the time. And we actually nudged the model with a very sophisticated statistical approach to fit the old model to the new situation. And when we later on assessed the impact of this model, we approached over 200,000 individuals in as early as March, April 2020, and told them there's a new disease called COVID-19. You haven't heard about it, but our data suggests you are at the highest risk. Maybe you stay home and you don't come and take physical care. We'll give you online care if you need it. And so by using, we later on assessed this model, and it was accurate. Within 7% of the population, we found 70% of the potential deteriorators. So this is an example of what you can do even when you don't have data, just by trying to couple data from different places. So you had 2 other, I think, interesting questions, and I would just one. We are more and more working with the private sector. We have created platforms that allow us to make our data accessible in a safe manner to partners that help us develop new interventions. And by working with industry in a very careful manner on this anonymized and within the system that we have, allows us to be able to harness the power of industry in a careful way in order to increase our ability to create new platforms and new interventions.
Well, thank you. Maybe we can agree on everybody who gets on the line has one short question, and we try to answer that because I would like to do then a final round of things. So please start.
Yes, so my name is, thank you, Jean-Philippe Ampana. I'm directing a research team in Paris on the field of cardiovascular disease, and I have a chair in global health in Paris as well. So maybe I will take you a counterpoint from Dr. Standinger, because as far as I understood, you said at some point that the patient didn't want to be bothered with let's say, being active in his in prevention, and I think completely different. To my view, one challenge is that how you make people being active of their health, especially when we talk about prevention. And so my question to, in fact, all of you would be in the field of prevention and digitalization. One major challenge is how make people being even more active of their health than it was before.
So thank you very much for raising that topic, because it gives me the opportunity to also maybe correct a misperception. Yeah. What I was trying to describe is we want it to be convenient, yeah, but also to make it easy to be involved, right? So you want to, if the things you can do and the triggers you get come to you, it's much easier than if you have to go somewhere to take care of things. So what I was trying to outline was very much also incorporating the idea that people, it's most effective when people take ownership of their own health. Yeah, that's the strongest piece. And the idea was to make it as easy as possible. So there is no contradiction. It's very much in sync what you've outlined.
But I think it's a really important question, because it starts to deal with the individual capability of taking responsibility for your own health. And this is something I would like to discuss with you in the final round, because it goes into the social context. A couple of people in the chat also asked that. Then it's you and then you.
Thank you very much. My name is Alexandra Schuster, and I am a mental health consultant at International SOS. I'm also on the Youth Council for the Canadian Mental Health Commission. So my question is, because I cannot do once, the models we create are only as good as the data we use to create them. This is actually for you, Elizabeth. And the research has shown that biases in data can perpetuate inequalities, specifically in predictive modeling, whether it be gender inequalities or inequalities in race, et cetera. So my question to you is, how are you working to overcome these biases that may come up?
I think, again, very valid point, yeah, because if you train your algorithms based on not diverse data sets or then you also get bias into what the recommendations will be, and there I think the approach has to be that you try to do two things. First of all, that you create a reasonable representation, yeah, of data sets which also reflect the population you want to work with. And the second topic, which I believe is very important, transparency, yeah, around that, yeah, because there will always be deviations from the kind of, yeah, place where a certain algorithms is deployed from where it was trained. So I think it's being transparent is probably the one big element.
Oh, and NHS has huge data sets. How did you tackle this problem, or?
Well, we are certainly very concerned about the problem. I don't know that anyone has solved the problem. I think it's one of those things that we will have to keep managing, and we have to be vigilant. And there are several techniques. Some of those techniques are governance, information governance, rules and procedures, and some of them are quite technical, how you build algorithms, if you'll pardon the expression, how the algorithms learning is governed. You can have tighter and looser models that has different implications for this. So very important question. I expect that this will be a fantastic opportunity for people all over the world to participate in healthcare, because to the point about transparency, when we make algorithms transparent, then we allow everyone to participate in the testing and questioning and challenging, and we will get better faster if we allow everyone to participate in that process.
Okay, thank you. Yes.
My name is Jürgen Brandstetter. I'm from Austria. I'm working in the field of digital health information exchange standards. My question is a restatement of the question earlier to Ran. We find in Austria it very difficult to get the population to take this responsibility on their own health. We have one series after the other of prevention programs which run more or less smooth. It seems to work in Israel. So Ran, is the digitalization actually the magic which is needed?
Can you answer, Ran?
Yeah, absolutely. Thank you first for this question. I think that there are several things to note. I think one, I think the key is not in digitalization. I think the key of our success lies in the trust between a GP and his population that he cares for. And the fact that the connection, Israel's healthcare system is very much leaned into outpatient care rather than inpatient care. We have an unproportional amount of our budget that goes into the outpatient care as compared to almost any other country. And I think this is one of the key secret sauces to dealing in an era of non-communicable diseases, is a strong infrastructure of general practice that is readily available and with high access to the entire population, especially within the lower socioeconomic groups, is a key component in allowing the population to participate in maintaining their health. Now, this type of ongoing connection that exists allows us to leverage on it. And when the physicians come to the patient, and then we come to the second point, which is, I do not believe in black box models in which you are telling the, trust me, this is the case. The physician needs to understand why a specific patient is at high risk for a specific outcome and be able to articulate that to him or her in a way that is comprehensible. And so when we created our platform for predictive modeling into practice, we used a format in which when the mouse over the specific risk score, you can see why that individual patient is at high risk for that individual outcome. You can see that the fact that he's smoking, or the fact that his blood pressure is uncontrolled, or his diabetes is out of control, or any other component of his modifiable behaviors is to blame in the outcome that he has, why he is put at harm's way, and what he can do in order to prevent that. And that type of discussion between the physician and the patient allows us to get better willingness to participate from the population. The final point that I'll mention is that the type of care in Israel that is population health, rather than episodic acute care in points of breakage, in a hospital care approach, the fact that the patient is used to the fact that there is someone that's taking care of him on an ongoing basis allows them to approach them even out of the blue, and they will be willing to accept that phone call and to trust what they're getting because they are used to it as part of their mundane care. And it's not like somebody coming out of the blue and giving them an advice that they wouldn't know whether to trust or not.
Thank you, Ran.
Thank you very much for your valuable insights. My name is Pablo Freudenthal, and I have contributed to the design of the electronic health record in Bolivia. I am also conducting a project funded by the GIZ to include data on congenital heart disease onto that record. Now, Ran said something very interesting regarding the remuneration of physicians for data input. So that rings a bell for me and probably for many of you that work in developing countries and struggle precisely with getting your physicians, your nurses, and your health workers onto data input when they have so many channels and when the channels are not unified. So I would just like to ask the round, how do we make this sustainable? Do you have, what has been your experience, Ran? And I am also very curious about your experiences and best practices from Asia. Elizabeth, Shobana, and of course, everybody. Thank you very much.
Okay, I don't think that we have time to go to the entire round, although the question is very interesting and Tim may answer it.
I think we are coming out of the slough of despond of data entry by clinicians. And what I mean by that is the impetus to get structured data by people like us has been so great. And the EPR systems have then responded by structuring more and more data. And that has put an enormous burden on the people delivering healthcare to input data in a structured way. This is not why clinicians went to medical school. And there have been estimates in the US that 30% of nursing time, you could actually increase the entire nursing workforce by 1/3 if you didn't have them sitting at a computer entering data. That's an astounding statistic, but very believable. But the solution, I think, is also through technology, and that is when an airline pilot finishes a flight and lands her plane, 100% of what she has just done is documented, but she documents nothing. That is called ambient documentation. The process of documentation occurs through your work. The technology necessary for ambient documentation exists today, as we heard earlier. All the technology exists. We just haven't implemented it. There's budgets, there's logistics. But that should be our aspiration. Our aspiration should not be to have highly trained clinicians entering data into what are effectively spreadsheets. What they do should be documented. And I'll just say, I participated in a trial of this in which there was a microphone in the room that created through natural language processing a transcript, but then further, the computer took that transcript and reorganized it into a note that a physician would write. It was an astounding experiment. So it is, as the saying goes, the future is here, it's just not equally distributed.
Well, yeah, and I think you have these discussions sometimes in the hospitals about this permanent recording. For example, if you talk to surgeons or other people who have to take really risky decisions, it sometimes puts a high burden of stress on them if they know that every single step is really recorded, and so you have the human on one side. It's the same with the pilot, but I think there are distinct differences. What I would like to do now is going back with a question around regarding the social part of our entire enterprise today, and it comes up with the questions from the chat as well. And then once we've answered that, if there's time, we go back to the audience. People are asking two things, and we will start with Molly again. In this entire complex we discuss, what's the role of, for example, social media in this preventive part? I mean, you're in the world's famous institution. I guess the social media part is as important for you as for others. And something I'm really, I think we should discuss is another question: how can you guarantee accessibility? Somebody writes from the UK. The question: how can digital technology to be developed to serve illiterate people? In the UK, 16% of adults are functionally illiterate and 20% are IT illiterate. And so it's an interesting question. If you go in this direction, in particular into this digital direction, how you can create a system which is independent of the individual capabilities. And maybe we can discuss this in a round and start with you, Molly.
Sure. Well, starting with the last question, that is a really interesting conundrum. And honestly, I don't have the answer to that. That is, that is something that we were absolutely are going to have to tackle. As we want to serve underserved communities. But, the digital transformation has really shifted on how we engage with our patients, and absolutely post-COVID, people, there's been an acceleration in the engagement. People are now much more comfortable, I think, having telehealth, right? Or they're much more comfortable going and searching out the answers before they would even call Mayo Clinic. And we have found that because as we think about the engagement on our .org website, the number of visits, and we can track to some degree where they go and what they're looking for. Our social engagement, we have increased all of our social. I mean, who would have thought that Mayo Clinic or frankly, any medical institution would have been on TikTok? I mean, we are going where the people are wanting to consume that data. Similarly with YouTube, we are partnering with them not only to get the right information out there, but we're meeting people where they are. And so social has become much more prominent just even in the last few years. And I've been in the business for 25 years. It has emerged as really one of the most important channels that we utilize in order to get to the right audiences, as well as the right messages to the right audiences.
Well, thank you. And Shobana, you mentioned that you try to get remote areas with these approaches we talked about. I guess the problem of potential inequality in using these tools is also something you're dealing with.
So, I'm on the board of something called the Edison Alliance. This is by the World Economic Forum. And one of the things is, the intent is to get 1 billion people connected digitally. And my stream is actually healthcare. And what we're working on are different projects, but one of the exciting ones is it possible for $5 to be able to give people to give them basic healthcare, and in doing so, preventive healthcare for a year? And the $5 would include any number of teleconsults, any number of basic medication that they need for NCDs. And this is a precursor to the big insurance that India has. So I think that these models that you can do this within $5, if we can, and we've actually finished a project that has done this for 3.4 million people, and with 15 million teleconsults and 9 million lab tests for these people. And I think that if we can do this, then we really are addressing the inequality by giving them higher quality. And I think that should be the goal of whatever we're doing in the new digital realm, is that if it's going to create a greater divide, it'll never be sustainable. We have to be able to give people, just more than just for countries' GDPs, but I think for the social cause of being able to be equitable in medicine. And quite frankly, we're not a nonprofit. We're a for-profit company, but we continue to think on these lines. And I think that's where the lines will again blur, that people are looking to say that can through scale, we'll be able to do this. And I think $5 is a fantastic price, even for a country like India.
Well, thank you for this clear statement. And Tim, we had this little chat on inequality before. What was your opinion on that?
I've just been so impressed with people's creativity at solving problems. And sometimes that creativity includes digital. So for example, on the illiteracy question, so I know there's a clinic that has passed out iPads and run YouTube videos so that both the patient and the family get exactly the same information on preventive services, right? And really the only thing they had to be able to do was push the button, press play. So that is a creative manifestation where you're using digital in a context where actually the fact that person couldn't use more standard channels was identified because you had digitized information to begin with. So this is about the iterative process, as I said before, adaptive design, of segmenting the population, finding out exactly what they need. I also wanted to just reference something from the consumer industry, and that is most for-profit companies, especially hotel chains, have information about the contact preferences of the people who use their services. how many healthcare organizations, I bet Mayo does, actually maintain an inventory of exactly how this person would like to be contacted, with what frequency, over what channels. That actually makes sure that we're putting the choice back in the hands of the patient, even as we develop the digital infrastructure. There's no reason why that digital infrastructure needs to be monolithic. It in fact has the capability of opening multiple channels and having the patient again be in the position of deciding what channel they want. And if they want to do it the old-fashioned way with a phone, although my grandmother can remember when the phone was new, but still, if you want to use the old-fashioned way, that is it's not that digital is replacing all these things. It's just that it is a more efficient method that is in addition and allows greater productivity and contact.
It's not either or, it's a yes and.
It's a yes.
And, as you think about, the preferences, as you will, as you said, we absolutely want to create that personalized digital front door into Mayo Clinic, because we want to serve up information that is relevant to you and what is important to you versus, spamming you, if you will, with a lot of information and data that frankly, you're not interested in receiving. So that's really the whole personalization that we talked about very early on is going to be really important going forward.
In that frame, there was a question from the chat to Ran. In which way did you take ethical considerations into account when you design individual interventions, and how was the reaction of the identified patients?
So basically, I think any project that we do and any data analysis goes through a very orderly process with ethics committees involved. And we talked before about biases in using an AI. And I think that one of the things we try to do in creating those models is try to make sure that we introduce as little of these biases into the actions. First of all, by reflecting any of the differential impact that this might have in different subgroups, and then trying to fix it with different technical methodologies of trying to reduce biases. Just to add to the discussion before about personalization, we are doing, I think, experiments that I think that are interesting on how differentially tailored messaging can allow us to motivate the public to do the right thing. And the same tools that Amazon used to make you buy a product can be useful for us to drive and nudge us and nudge the individual patient to improve their health. So what we've been actually seeing is that when we are using behavioral economic approaches to increase willingness to respond, there is quite an impact. We showed that differential messaging was able to change things like COVID-19 vaccination uptake on the short term. Or for an instance, when we used AI-driven approaches to personally adapt messaging through SMS to make this available to any patient, we used differentially crafted messages within SMS, and we were able to reduce no-shows by almost 40% by driving the right message to the right person at the given time, by being able to predict what kind of messaging would be most impactful in taking into account their socioeconomic background and various other aspects. So I think we can actually, while the digital divide could be a problem and worsen disparities, we can use the digital transformation to have new tools to tackle old problems.
How's the view of industry on that? I guess if you want to go to your digital twin, it's also an important problem to communicate that to patients and to users.
Right, and I believe we've heard wonderful examples of what works, yeah. And I would really say that the opportunities of digitalization and social media have made the entry barrier lower than it ever has been. Yeah, so I think as there may be this effect of maybe this creates some disparity here and there, I think we've never had that type of opportunity to reach everybody anywhere in the world as we have today. So I would really look at this as an opportunity and not a problem.
Okay, Tim?
Well, I just wanted to, if I were to look at my life or my family's life in the exposure to social media that is health damaging and health promoting, there is, we have a long way to go before we are exposing people in our societies to a balance that's or even a more balanced situation, never mind. And that is going to be a shared public health challenge.
Okay, there have been a couple of other questions you want to ask. So we have 10 minutes left, and I think it would be worthwhile to use these 10 minutes in an interaction with you as an audience. So we'll try to answer your questions.
Thank you for that. My name is Soz, and I'm representing the International Pharmaceutical Students Association, Federation, sorry. And I'm also working for the NHS, so I'm from England. And I had one question in terms of, I guess, in terms of health inequalities, really, just something similar to what you were discussing. I know that health inequality is a big problem issue in England, and it's been really highlighted throughout the COVID pandemic. And I know it's part of the NHS long-term plan. And I was wondering how the data that you collect, you make sure is inclusive and representative of the diverse population that we have, because although the people that work for the NHS are very diverse, but a lot of the times we've seen that the data collected isn't really representative of the population that we have. And it's probably why we have the health inequalities in our long-term plan. So I was wondering, well, how do you collect it to make sure it's representative, or what plans do you have in place to work towards that?
Sounds like a very specific NHS question. But I might broaden it a bit and just say that the challenge of understanding our populations that we want to deliver services to it's a long-standing challenge, and there are some significant issues associated with the collection and recording of that data, particularly when people have a choice about whether or not it is collected and recorded. And giving them that choice, I think, is a requirement. Certainly, I believe it is. And so that puts us in an interesting situation with respect to understanding. Now, we can build understanding around, and there are ways of modeling and imputing data. They're all subject to biases and challenges. And so what I see, though, over time is that most health systems, I think the NHS included, I'm sure the NHS included, is getting better at this. But there's still a ways to go. We do, in fact, have very specific plans, and our health inequalities group under Bola Olawabe has published some very specific plans around the collection and transparency of our data with respect to different population characteristics.
Thank you. There's a question in the back.
Good afternoon. My name is Vince Lopez. I'm from Parker Health in the United States. Just curious on a couple of things. You guys have been talking about AI, machine learning, et cetera, but in the US, we're moving towards new standards underneath FHIR, which is the Fast Healthcare Interoperability Resource Program, which is an HL7 build out. My question is around those standards. The WHO is starting to adopt some of those under their SMART guidelines into technology. What regulatory standards are you looking at? What are you looking to use in not just AI and ML, but integrations with electronic health records and other things like machines that are being used?
Here's a question to the large organizations like NHS or Rand Balitzer. You want to start?
Well, it's really, really important from multiple perspectives to have data standards, because everything we've been talking about is based on a presumption of interoperability. Interoperability is something that society needs, but individual vendors of healthcare systems may want to avoid. And so there's a tension, and maybe I should have my Siemens.
Respond to that.
Yes.
But you finish your point.
Yeah.
first, please.
Well, let's just say there are definitely certain situations where avoiding the use of standards, but I think in the long run, industry has benefited dramatically by increasing markets through the use of standards, and of course, the famous thing is just the plugs in the wall. Although I will just say my UK plugs do not fit in these. Actually, to continue that analogy, the standard, it's always a process through standards. I will just say that my personal hope is that the COVID pandemic will make us work much faster in adopting the fire standards, and smart on fire and HL7 and all of the various approaches, because the more we adhere to those standards, the more rapidly we will be able to create a worldwide view of the next pandemic. And this is a critical piece of the puzzle. So I'm parochially within the NHS, we have a long way to go for adopting and encouraging all the tech vendors to adopt fire. But actually, it suits everyone if these standards are not national but international because of pandemic preparedness.
Okay.
And I would like to, if I get a chance to respond, we love standards, And the more global they are, the better it is for us, for industry, for patients. And one very good example is if you look at imaging, there is a standard called DICOM, how you code image information. And the introduction of that standard made a huge difference for everybody, because it reduces cost, it makes it easier to deploy. There is just so much upside and benefit. So you can be certain that we will be at your side when it comes to advocating for interoperability and joint and ideally global standards.
Can I really quickly come back? So
do it quickly, they're torturing us with signs.
So DICOM was a huge leap forward, correct, but DICOM doesn't actually solve all the interoperability issues associated with images.
We want.
And so I want to just say, so I still have to do, in order to create AI algorithms from different vendor systems, those are completely different formats, even though I can read them through the DICOM standards. And that is the story with all standards. You make a start, everyone moves into that. It helps, but it doesn't solve the whole problem. And then it's time to do it again and again and again.
Okay, so we have one final question. They are torturing us with signs that it's over.
Thank you so much. Francesco Florini from Thermo Fisher Scientific. We're helping also bringing some of these new innovation in prevention. So my question is, we heard that the technology works. We heard that the standards are coming and they're getting better. We heard, we know that the science of some of these new, you mentioned genomics. We know that predictive genomics, for example, works and the science is there. So my question is for the panel, apart from Ran, of course, because you're already living the dream in Israel, it seems to me. What would you say to policymakers? What's their number one priority to bring these technologies that, again, work forward, not just in Europe, but also across the globe? Because, again, when it comes to genomics, it's something that sounds pretty expensive. We can talk about how expensive it is. But more importantly, how do we convince policymakers to jump on board of the consensus that I see at the table? Thanks.
Okay, as we run out of time, I might try to answer that for a country which is not really good at IT in healthcare, like Germany. And I think the way we try to convince policymakers is showing examples. We took Ran Ballitzer to the Chancellery here, showing what Israel can do and what could have been done in Germany in the same way if we would have had these type of systems. So the way is showing working examples all around the globe and trying to convince first to get the political will, then get the funding, and then get it done at the end of the day, where you can see in our country that it's quite difficult. So we're exactly at the end of this meeting. It's 5:30. I would first like to thank the speakers for their engaged discussion.